Himanshu. I must thank Dr. Chitra and ARC for giving this fantastic opportunity. And on this Guru Purnima day, I don't not only thank my gurus, I thank my parents, my wife, my son, my friends, my associates, my juniors. They're all my gurus. They teach me. They teach me not just surgery, they teach me life. They teach me to have fun. They teach me to live life full. So I'll just start with my video. My video will have some very instinctive. Can you see the video? Hello?
No, we don't.
Okay, I'll just go on again. Is it
Yes.
on?
Yes.
Okay, so as the topic says, simple tips for complex situations. Whenever we get a little overconfident, we're in a hurry, we make a mistake. And if a mistake is made by a mistake, I called it galti se mistake. So this is a kind of funny situation. There are no financial disclosures here. One disclosure which I have is I firmly believe in having a very relaxed and a cool mind. My friends who know me, they think I'm a very high energy person. I'm a lot of clutter headed, but deep inside, the trick is to have a very calm, relaxed mind. So this is what this video will show you. This is a situation where I'm operating a VIP patient. Mostly these things happen in a VIP. He's a politician's younger brother. He's come to me for a femto-cataract surgery. And I will proceed. Everything is over. Everything is perfect. I'm in a hurry to finish it because I'm trying to show him the speed, because he's heard that probably.
Dr. Kamal Kapur, if you can just stop the audio music from video, please.
Is it better now?
Yes, perfect.
Okay, so I'll start again. The surgery is over. Everything is perfect. I'm in a hurry to finish the case and, probably talk to the gentleman. I go in with my irrigation. You can see a femtorexis. And I just go in. I go with my coaxial area. Just watch out. See what I do. And I stop the video here. Just see what I've done. I've pulled the whole cortex along with the capsular bag and the anterior capsular rexis in. And if you actually see that, I will redo it for you. See how hugely careless I've been. You can actually see the anterior vitreous face intact and the capsular bag being disrupted from the anterior vitreous face. But the trick is calm mind, relax, not panic. So I go on my reflux mode. See what happens. I go on a reflux mode and I catch it again on the reflux, which means when you go on a reflux, immediately after reflux, we should slightly move the irrigation aspiration port backwards. What I did was I went in the irrigation mode and my aspiration port was nearby. So on the rebound, I caught the capsule again, but I did not panic again. I kept it there. I kept my hand steady and I remembered that I do have a left hand also. So what did I do? I'll repeat again. I used my left hand to disengage the captured capsule on the reflux. Now I use my left hand very, very gradually. I've kept the irrigation on. And as the viscoelastic is going in, now remember, the viscoelastic goes in the bag, not on the bag. Oh, sorry. The viscoelastic goes in the bag. And what happens is, if you put it in the sulcus or on top of the bag, you will invariably break the vitreous phase and push the viscoelastic behind. So pushing the viscoelastic in the bag, and once you start pushing, only then your irrigation has to stop. Till that time, keep a slow irrigation on. So you will notice I pushed the viscoelastic in the bag and I pushed the subluxated part of the capsule behind. Now I fill it, but I do not overfill it. Now is the time to put in a CTR. Now, once you put in a CTR you should know the axial length of the patient and the white to white. I normally use a standard 12 mm, but if the patient is having a more than 25 millimeter of axial length, I go in for a larger CTR. The vectors of CTR are very important. You should not do a rotation movement or a tangential movement on the CTR when you're injecting, because you might dislodge it more. So I use the hook technique. I use different kinds of techniques to put in a CTR. Now this is done. My bag is stable. Now comes the second problem. Removing the cortex, which is stuck up behind the CTR. I would recommend using a Simcoe, especially in the area where there's maximum amount of subluxation. Be sure you do a sectorial removal of the cortex. Do not go in for a larger chunk. Do not be greedy. Hold out one sector apex of the cortex, triangular apex, pull it. Do not be harsh, because sometimes if you're harsh, you might end up pulling the whole bag complex along with the CTR, And now you have a subluxated bag and the CTR in the vitreous. I slightly fast forward the video here too. Now you notice the cortex gets stuck behind the CTR, so it's difficult to come out. But a very gradual pulling. A lot of times, if you keep losing the cortex, it's a good idea to let go of the vacuum and re-grasp again. Make sure when you're doing it, the bag is not collapsing. So you will notice I pull it, I re-grasp it. I pull it, I re-grasp it. Till I get a purchase on a thicker part of the triangular part of the cortex. Do not keep pushing on pulling. Pull, aspirate, combine this movement to nudge the whole cortex out. Now, I have not gone to a bimanual in this stage because I am very comfortable using this. I use a lot of bimanuals also where here I'm feeling I'm able to do the job. The most tricky part probably in this situation would be the sub-incisional, where a lot of my colleagues would say, okay, you can actually use a bimanual. Because for that particular maneuver, using a Simco is tricky, but I somehow am able to manage it. This is what I would normally do, but in case I am getting stuck up in this situation, a tip for all beginners is at this stage, you can actually go in for a bimanual. I usually would not prefer a bimanual to start with, but if you go in for a bimanual, make sure to lower your bottle height slightly because you have a huge area of loss of zonules. Now, once this is done, I've shifted to a bimanual, low bottle height, because I've already filled the anterior chamber with viscoelastic, so I don't need much fluid coming into the anterior chamber. The bottle height is approximately 60 centimeter, and I'm using a lot of viscoelastic to keep my chamber filled. Once this is done, I keep my irrigation on, and then I push in viscoelastic, and then I remove. Never over-pressurize the anterior chamber in these situations. Now, the angle or the direction of the lens should always be in the straight axis of the maximum subluxation. But remember, the maximum curvature of the loop has to be in the maximum area of subluxation, not your optic haptic junction. So approximately 30 degrees away from your optic haptic junction would be the maximum curvature. Now with the lens in, I go in and complete my irrigation aspiration. The whole thing is done. And each time this patient comes for follow-up, this is approximately a 2-year-old video. And this person, it comes with a lot of security guards into my clinic. Each time he comes in, invariably, I dilate this eye because for the patient, he's absolutely symptomatic. He wonders, why does Dr. Kapur always want to dilate this eye to see? So some points to remember, never be in a hurry. This was the result of a hurry. Don't get startled. Never get panicky if you hold the capsule. Don't suddenly come out, you'll pull out the whole capsule. No jerks. If you held the capsule, keep your hand steady there. Do not give any jerks. Remember, there is a reflux mode. Your mind should not freeze. Go on the reflux mode. Remember that you have a left hand also. A lot of times when a beginner surgeon freezes up, he forgets he has a left hand. Side port viscoinflation, it has to start and then you have to stop the irrigation. Don't keep both of them on. Otherwise, you'll create a further breakdown of the anterior vitreous space. Visco has to be put inside the bag, not over the bag in these cases. CTR direction vectors we already mentioned. And the removal of the cortex, do not be greedy and try and pull the whole cortex at one time, because in this situation, you might dislodge the CTR and pull the capsular bag inside. Repurchase, in case you're not able to get the cortex in, hold it, pull it, repurchase on a thicker area, repurchase and do a gradual combo of push and pull, and always be very careful in the area of subluxation. Thank you.